Assalamu alaikum. I am Dr. Shahida. Welcome all of you to my channel, Online Teaching of Obstetrics and Gynecology and Treatment. My today's discussion is Asherman syndrome. First of all, we have to know what is Asherman syndrome. It occurs due to the formation of adhesions between the two layers of the endometrium following vigorous curettage of the basal layers of the endometrium. Almost invariably, it is preceded by superadded infection. What are the causes of Asherman syndrome? Most commonly followed by curettage for secondary PPH after full-term delivery, and the PPH may be due to retained placental bead. Much less frequently following curettage for induced or incomplete abortion causing removal of the basal layers of the endometrium. The basal layers of the endometrium must be injured for the Asherman syndrome to occur. Very rarely following diagnostic curettage for abnormal uterine bleeding. Operative hysteroscopy may cause Asherman syndrome. Operative hysteroscopy such as after removal of fibroid by hysteroscopy. Rarely it follows tubercular endometritis due to adhesion formation by endometrial ulceration. Schistosomiasis is a very rare cause. It may occur after C-section when lynch suture given for control of intrapartum hemorrhage and followed by intrauterine adhesions. How will you diagnose Asherman syndrome? For diagnosis, we have to take history, clinical examination, and some investigations. What about history? History of menstrual disturbances such as hypomenorrhea, oligomenorrhea, or secondary amenorrhea. You have to know what is secondary amenorrhea. When menstruation is absent for more than 6 months, it is called secondary amenorrhea. History of infertility and history of tuberculosis. And what you will find by examination. Usually nothing abnormality can be detected in general per-abdominal or per-vaginal examination. And what investigations you have to do for diagnosis of Asherman syndrome. The hysteroscopy is the gold standard investigation for diagnosis of Asherman syndrome. It reveals the extent of adhesions directly and it is confirmatory. Avascular bridges joining the anterior and posterior wall of the uterus are found. Saline infusion sonography is the second option and hysterosalpingography is the third option. It shows honeycomb appearance. Saline infusion sonography and hysterosalpingography has more sensitivity but less specific, means that it may give false positive result. And progesterone challenge test by giving the medroxyprogesterone acetate 10 mg daily for 5 days or progesterone 100 to 200 mg intramuscularly as a single dose. No bleeding occur. This is expressed as progesterone challenge test is negative and it is diagnostic of Asherman syndrome. Estrogen progesterone challenge test by giving conjugated estrogen 2.5 mg orally daily for 25 days plus medroxyprogesterone acetate 10 mg orally on day 16 through 25. Patients with Asherman syndrome do not bleed following this regimen. And Asherman syndrome can also be diagnosed by weekly serum progesterone test. Any value in the ovulatory range more than 3 nanogram per ml not associated with menstruation is indicative of Asherman syndrome. Some hormone analysis may be done. This is serum FSS to exclude ovarian failure and hypothalamic dysfunction. Over 40 milli-international unit per ml indicate ovarian failure. Under 40 milli-international unit per ml indicates severe hypothalamic dysfunction. Serum LH and FSS and LH-FSS ratio to exclude polycystic ovarian disease. Because in polycystic ovarian disease, there may be amenorrhea. Serum TSS level to exclude hypothyroidism. Hypothyroidism may cause amenorrhea. Serum prolactin to exclude the causes of hyperprolactinemia which may cause amenorrhea. Tuberculin test, ICT for tuberculosis, X-ray chest view and complete blood count. Now, what about the treatment? Whenever it is confirmed that it is a case of Asherman syndrome, the treatment must be done according to need. Now, what is the treatment of the Asherman syndrome? resection of the intrauterine adhesions by hysteroscopy. This is the first foremost procedure. It is called metroplasty. Sometimes laparoscopy and metroplasty done by side because during hysteroscopy there may be perforation of the uterus and it is more common. After adhesiolysis by hysteroscope, then you have to insert one pediatric Foley's catheter and kept in situ for 5 to 7 days to prevent further adhesion between the two layers of the endometrium. To keep the two layers of the endometrium apart. If this is not available, we have to insert intrauterine contraceptive device and kept in situ for 3 months. In that time, for regeneration of the basal layer of the endometrium, we have to give equine conjugated estrogen 0.625 mg in BD doses for 3 months. It will cause regeneration of the endometrium within 3 months. Antibiotic must be given to prevent infection. In tubercular endometritis, at first you have to treat the infection by antitubercular drug as per need, and thereafter adhesiolysis is done. If you done adhesiolysis before, then it may cause flare-up of tubercular infection. In most cases, the condition corrects within 3 months of this treatment. What are the complications of Asherman syndrome? It may cause infertility, it may cause abortion due to implantation difficulty, and preterm labor due to accommodation problem, IUFD and IOGR. Placenta accreta followed by retained placenta due to the defective or absence of decidua vajalis. And now, what is therapeutic Asherman syndrome? The therapeutic Asherman syndrome is done for abnormal uterine bleeding. This is the transcervical resection of the endometrium or laser ablation on the endometrium may be done in case of abnormal uterine bleeding. Alternative to hysterectomy using iliac laser through hysteroscope. The principle of this operation is to destroy the basal layer of the endometrium up to a depth of 3 to 5 mm. And further regeneration of endometrium because of destruction of the basal layer, there would be no further regeneration of the endometrium because of the destruction of the basal layer as well as the basal and spiral arterioles of the endometrium. Now, there is a recent invention of stem cell therapy may be given in case of Asherman syndrome for regeneration of the endometrium.